So the topic of my presentation is complex Descemet stripping endothelial keratoplasty. So DSEC is pretty straightforward when the iris lens diaphragm is intact, either a crystalline lens is present or a well-centered PCIOL is present, because it offers resistance to the air bubble that we place at the end of the surgery. But if this diaphragm is compromised, then that effective tamponade is not possible and chances of graft dislocation are more. For example, patients who have PC rent or vitreous in AC, we need to do a concomitant iris claw, SFIOL, or there is a functioning glaucoma valve or trap which provides egress to the air that we put at the end of surgery. Also, presence of peripheral anterior synecdoche and shallow AC also make the surgery a little tricky. So ideally, if secondary IOL is to be done in patient, then DSEC and IOL implantation should be done in two settings, at least 1 month apart. However, sometimes it's not possible and we need to do it together. In such cases, the problem arises is because the eye tends to be on the softer side at the end of surgery, that effective air tamponade is not possible. So no matter what we do, the tight airfill that is required after putting in the graft is not possible. There are certain things which we can do to enhance the success rate of our surgery. That is, instead of keeping that air bubble for just 10 minutes, we should put it for at least an hour. And a good surface massage is also very important, because if there is no interface fluid and the graft starts working and starts absorbing the fluid, then it tends to create a sort of suction and the graft sticks to the host. Another thing that we can do is that we can use C3F8 or SF6 non-expansile mixture, which provides a longer tamponade as compared to air. So poor visibility is expected. However, sometimes we need to do some extra maneuvers inside the eye, like seeing how the IOL is there. So for those cases, apart from doing an epithelial debridement, we can use a light pipe during those crucial steps. And the second thing which I have found useful is that filling the anterior chamber with air bubble for some time also leads to reduction in stromal edema temporarily, and for those crucial steps the visibility is enhanced. So descemetorexis should be ideally done under air because the visibility is very good. Also, if there's any vitreous in disguise, then it shows. We can see pupillary peaking and the air bubble will be dimpled on some side. So it is better that we put an air bubble and then see what is inside the eye. If we feel that the eye is not going to be very stable during surgery, we can use an anterior chamber maintainer for performing the rest of the steps of the surgery. Phacoemulsification with DSEC is actually simpler than what we would think it would be. Once a continuous curvilinear rhexis is complete and we have done the nucleotomy, we can prolapse pieces in AC. The endothelium is already compromised. We need not worry about it. All we have to take care is that the PC integrity is maintained. The rest of the surgery is like that of any simple DSEC. So if the AC is shallow, I would say that DMEC would be a better option because the graft is thinner. We should do a PI so that there's no risk of pupillary block, and we should use a smaller graft. And every attempt should be made to release the peripheral anterior synecdoche, because that will help us use a bigger graft, and also it will not threaten the immune privilege of the cornea. So pupilloplasty should be done wherever possible and needed. However, in some cases it is not possible. The iris is very floppy, it's beyond repair. In these cases, like for example in this case, when I inserted the graft, the iris got in between the donor and the graft. So gently nudging the iris away from the graft, taking care that the endothelium is not touched, and then we put a small air bubble and suture all the ports, and then in the end, instead of a cannula, we use a 30 gauge needle to help keep that iris away from the graft. This is the post-op picture. If there's a functional trap or glaucoma valve, plugging it with viscoelastic before air insertion also prevents air egressing out of the eye. This slide I have added because it was an interesting case of a bee sting injury in which there was a pericentral sterile infiltrate and scarring, and the DSEC worked well for this patient. This is another patient in which we think that patients who have any bit of stromal scarring will not do well with DSEC. It is not true. If there is anterior stromal scarring, then DSEC works well. It takes time for cornea to clear, but it works. So this is a photo showing pupillary block. We can do burping, or actually in this patient the PI was not very peripheral as it should have been. So if it happens, we can either do burping or ask the patient to slightly bend and keep his head towards his knees in regular intervals so that the air is able to move in the anterior chamber. So in the end, I would like to say that decision making and patience are required in complex DSEC cases. Thank you.
Thank you for finishing in time.